Well, welcome to our podcast series, The Cutting Edge. This week, we're glad to have an absolutely fantastic friend and colleague from the United States. We have Dr Keller. She is Associate Professor of Surgery, and I'm sure many of you know her strong and robust research portfolio. Debbie's going to join us for this conversation and give her thoughts around a variety of subjects over the next 20 or 30 minutes or so. And I'd like to extend my welcome also to my host, Professor Venky Munikrishnan. Venky, I hope you're doing well. Let's have another good chat.
Yeah. Hi, Debbie.
Hi. Good morning, guys, or good afternoon there.
Welcome to the show.
Thanks for having me. Very exciting.
So how are things in New York? Is that where you are at the moment?
Yes, I'm in New York at the moment. Things are okay. It's definitely not normal. I don't think it's normal for anyone anywhere. A mixture of the virus and the riots have closed down a lot of stores, a lot of restaurants, and they haven't reopened. Not many people out on the streets like we're used to having, which New York is known to be such a lively place. Like went for a run in the park this morning and you could count the number of people out. So it's sad, but things are okay.
Look, I hope we can at least then take this opportunity to get your thoughts on a few things whilst you are cooped up inside in your residence in New York. So we thought that we would start with one of the research topics and one of the clinical topics that you're known most about, I suppose, and that's enhanced recovery after surgery. Mm-hmm. And of course, many of us now think that this is routine for our practice, but tell us some of the challenges that you had and in the various institutions where you went and set up this and some of the success as well to setting up an efficient enhanced recovery program.
Sure. I think just what you said, that many people think that it's routine, is the first fallacy. Because even though more people are aware of enhanced recovery, it's a concept that's been out since the 80s, most people don't routinely do it, or they do parts of it and think that they have it down, or they don't monitor their patients. And that's the biggest thing. I trained for residency. It's different training schemes in the US than it is in the UK, but residency is 5 years. And where I trained was basically a trauma center, which was great volume, but there was no enhanced recovery whatsoever done. And I went and did fellowship with Dr. Delaney, who is really the godfather of enhanced recovery in this States, and it was like, why aren't we all doing this? Why aren't we doing this in all patients? So that was a wonderful learning experience. And then leaving there and going to different institutions where partially some partners would do it, some partners wouldn't do it. Residents taking care of patients weren't following through on orders. There were no nurses monitoring compliance. Patients really didn't have the health literacy to follow it. You learned a lot about putting it into place. So it's been a wonderful learning experience to the point where now I can put these programs into place, really survey the local knowledge, the knowledge of everyone that's going to be taking care of the patients, from the stoma nurses to the residents, to the physical therapists, to the PACU nurses and OR staff, and understanding the different phases of enhanced recovery, from prehabilitation to intraoperative to postoperative, and then once post-discharge, monitoring the patients and implementing different technologies to help patients, which is even more important now with COVID, and reducing opioids in patients, which is becoming a hot topic, and putting these through in all surgeries, and then learning how to audit the system so that it's like a toolbox that anyone.
Debbie, so we understand ERAS, we understand that it's important, and I think there are few challenges because people understand bits of it, but how to put it together and make it work as a program. And they also think, oh, there are so many different things to measure, right? So if I, as a hospital or as an individual consultant working with my team, decide to say, okay, this seems like great, patients are going to benefit, where do I start? Is there a space on the net, or documentation which is available, or guidelines from organizations, associations? So where can someone, sitting in the middle of nowhere but wants to the best for his patient or her patient, where can they start? Where do they need to look? And then how do they progress? If you can spell that out in a, sort of 1, 2, 3, that would be really helpful.
Sure. So I think the best place to start is the awareness that you need to change things at your own institution, and then finding the low-hanging fruit there. For some hospitals, it's high readmission rates. For some hospitals, it's long lengths of stay. For others, it's urinary tract infections or surgical site infections. And those are things that we all need to address to improve the quality and reduce the costs. So that's the target that you want to present to your C-suite when you're bringing the program in. So first is the awareness, second is the education of all of your staff, and it needs to be a top-down approach. Otherwise, if you don't have buy-in, then it won't be implemented at some level or won't be supported.
That's
and
very
then it's
important.
very important. And then it's designing.
So sorry, I was just going to say, well, it sounds like not only is there a clinical benefit clearly, but the hospital administration should be interested, because there's no doubt a financial benefit too.
There's a huge financial benefit. The lowest hanging fruit with enhanced recovery is a reduction in length of stay. And the most expensive part of a hospital stay is the beds. So immediately that's reduced. And then once length of stay becomes a process control factor, there's reductions in pharmacy costs, there's reductions in anesthetic costs, there's reductions in readmissions, there's reductions in the services and post-discharge facilities patients use. So there's a lot of financial benefits, and there's been studies that prove that the benefit is greater than the cost of implementing the program and even having a full-time staff member like the NISQIT program needs to monitor this. And then the third thing after education and really implementing it is looking at what's already out there. There's no reason to stumble with this because there's great resources such as SAGES that has published guidelines for every surgical system on the web, almost like a toolkit to help with the end-to-end education and implementation and then auditing of the system. And there's different tiers of this. You can do this yourself just with a staff member and Excel to audit the outcomes. You can use in the States a system like NISQIP, which is sort of like going from the Honda to the Cadillac system, where they will come in and they'll monitor the variables for you and come up with your own specialized reports. And if you want to go from the Cadillac to the Lamborghini, then ERAS Society actually has an amazing database system, but it is cost intensive to implement this and have it run at your hospital system.
So let's go from the Lamborghini to the future self-driving car and talk about how technology that we have at the moment, and perhaps technology in the future, can further augment enhanced recovery. I mean, you and I were talking about a study that we're setting up regarding wearable devices and how we can monitor patients post-operatively with the available technology, and how that may be a real game changer for getting patients home early and monitoring them remotely. But where do you see technology in ERAS going over the next 5 years?
I think that they go beautifully hand in hand, and wearables are just one part of it. We have wearables now in step counters and in heart rate counters, and it's advancing in apps, which are helping to both educate and engage the patients. The patients have to understand the system and be in agreement with all parts of it for it to succeed. And the beautiful thing about apps and technology is that without the patient being in front of you, the physicians have this on the back end so that they can engage with their patients, answer questions if questions need to be answered, reduce travel time, and really help the patients take care of their own care. Wearables will be able to get the data points that we need to make sure that patients are safe at home and on the right recovery trajectory without coming into the office. And that's increasingly important now with COVID. And in the next 5 years, when we have regional specialization centers, that will also help to keep the lengths of stay down without readmissions, without patients needing to travel back and forth.
So Debbie, so once we've got this program running, everybody's bought in, and we'll say, okay, well, we're going to start these programs, and then you have all this technology coming. Now, is there a way, we can do away with noting down all these different data points, or is it all online now? Can a doctor or a service wants to start this program with all the variables, all this technology built in, can they sort of log in all these details online, and all this information stays, and then you just get a printout to say, or the organization can have say, okay, it's Dr. Keller's service, We can look at all their admissions, discharges, how soon, it can be all online, right? I mean, there must be
It can be.
services.
Yep, it absolutely can be. And again, it's your buy-in. So for example, at Columbia where I was, there was no enhanced recovery system, believe it or not, when I came in to start practice. So I designed it from the bottom up. I didn't have the ability to have the Cadillac or the Lamborghini service. So it was really as simple as Excel, as designing the data points and even starting with paper at the very beginning, like a pilot, to show my division chief that this actually works, that people will be engaged in it. And then we designed it so that it was capturing from the medical record system and auto-populating in the back end. So designing a report, and we did report cards to start with every month, was as simple as just hitting the enter button for a macro button.
Debbie, you've been very active, and you've been a high collaborator with all the teams around the world, and it's great to have you in our group particularly, because we try to have a even match of even participation. Now, but it is a challenging world out there, both for all surgeons. Now, I want you to share your experience of what are the challenges you faced when you started out, and how you evolved into one of the premier surgeons in the world in your field.
I came up trying not to think about it. And I would tell my colleagues and tell the trainees under me, just be a surgeon. Don't worry about being a woman in surgery, just be a surgeon. But it is a huge issue, and it's getting better, but it's still not there. As a resident, I was the only woman with 7 men, and I survived again by just being a surgeon. But we are inherently different. We have some different needs. We are judged differently. And that does make things much more difficult. And as I've come up, I've learned that there are inherent biases. Immediately, the one time a year that I get angry, I will wind up in a department chair's office and I'll be labeled. Women are immediately biased as being emotional, aggressive, abrasive, overconfident. Intimidating is something that I get a lot, where anyone that knows me wouldn't brand me as those. But in general, women are just labeled in those terms just by their emotions, whereas their male counterpoints for the same action wouldn't be. And that's hard. And there's stereotypes, even as the playing fields are getting more balanced, that we're still fighting against. So I was the only female trainee at Columbia. I was the only woman in a group of 6 other surgeons. Immediately you get pushed the pelvic floor cases, which is a wonderful subspecialty, but I like rectal cancer, and it's fighting through those biases. There's cultural biases as well, and it's difficult. It is difficult. And we wrote this article with Dr. Wexner, which was really an amazing experience to look at the history of women in colorectal surgery. And I think that I wrote 35 papers last year, and this was probably the most meaningful of any that I had written before. And I had a chance to work with my mentors, Dr. Hull, Dr. Brown, Dr. Burho, Dr. Galangiak, and hear the stories of these trailblazers, which were amazing. Like, I literally laughed and cried and was so inspired and aspiring to accomplish half of what they've accomplished. And it meant so much to be able to hear their stories. And at the same time, it was very sad that we're still struggling. And we're struggling kind of in silence. There is more attention. People are ensuring that women are on panels, that women fill roles. But we're still struggling. It should just be surgeons and equal. And we're not quite there yet, but things are getting better. In ASCARS, Tracy Hull made tremendous strides. I'm so proud to have her as a mentor, but at the same time, it puts me in a difficult position with others that aren't ready for a strong female leader.
So I think you've very modestly described some of the challenges that you face. But tell us how you've managed to negotiate these challenges, because it has been a real pleasure when we've worked together. You are one of the leaders in surgery, regardless of gender, in colorectal surgery. You clearly have various skill sets, from research, clinical ability, mentorship, So how have you managed to do that in this difficult environment that you've described, and managed to do that successfully?
Well, it isn't always successful, and some of it is a smokescreen. And really, it's relying on my mentors and my sponsors to guide me. The things that are sometimes said and done to me will give me cause. And I've learned to not react immediately. I am sensitive. I do internalize things, but I don't react. And I'll talk about it with someone, with you, with Dr. Wexner, with Dr. Delaney, with Dr. Hull. How do I deal with this? This was just done to me. There's greater politics that are around it. Sometimes it's not just the individual who's doing it that's in charge of the decision. And those things are hard because you do want to react. And you know that a male would be able to react and not be branded from whatever that was, where it's not the same with a woman. So it's really relying on this net of mentors and sponsors that have been there, that know politics, that we don't want to be involved in as surgeons. We really don't, and can help guide you as successfully as possible through it. And also developing a thick skin, which is hard, and armor, so that when you're in the middle of challenges, you can stand there and take it and smile and keep your focus on the patient, regardless of what's happening inside.
Debbie, we're on to our last segment, and I would like to ask you about your views on international collaboration using social media, because that's become really powerful to get all of us together. Your views, please.
I think that it's been one of the greatest innovations in surgical research over the last few years. It's really moved competition to being a thing of the past, and collaboration and teamwork being the future. And social media has facilitated that more than anything else. It's a seamless connection. The playing fields are leveled. You can reach out and communicate with leaders of the field anywhere, at any time. And with that, there's been extremely meaningful and powerful work, such as the COVID surge projects, such as collaborations that we've worked on, major high impact journals, and you get a whole representative and generalizable view instead of looking at one institution or one country. And these things really wouldn't be possible without social media.
Absolutely, we fully agree. I think this whole program has come through collaboration, and we're in different parts of the world, stuck because of the in our individual homes, towns, and there we are exchanging views on social media and being connected. So yeah, I think it's the future. Manish?
Definitely the future. It's cost effective. It's seamless. It doesn't matter that you're in India and Manish is in London and I'm in New York. This is just seamless connection moving forward. Can't be stopped.
So, and I think there's a lot that we can learn from each other in terms of the sharing of clinical experiences as well as research. Of course, we were fortunate enough to have you in London with us as our fellow a few years ago, and I'm sure we learned just as much from you as you did from us during that time. And of course, we've co-authored many papers together, and I think having these collaborations really helps us as individuals and clinicians, but also I think we can learn so much for our patients. I mean, what we learned from you in terms of enhanced recovery, how things were done in hospitals in America, I think it's absolutely fantastic, and I hope that really continues for all of us.
Yeah. So I want to thank you for doing this, and this is just one example of international collaborations, which are just so important and have been so meaningful to me in my career. And I would just encourage others to reach out for mentors and sponsors. They don't have to be in your institution. They don't have to be in the field that you're working in. My mentors are not even in the same state or the same country as me. And they have helped to push me forward, to make me a better surgeon, to make me a better researcher. But it's just stepping out of your comfort zone to reach out to them. Be that medical student that stands in line to introduce themselves to a speaker. Be the resident that volunteers to go to courses, that takes on a paper in the time that is their spare time, because it means something to the mentors. Mentors will work as hard for you as you work for them. So be present, reach out for the people that you want to connect with. They will be happy to do it.
Thank you, Debbie. Thank you for joining us from New York, and Manish and from London. It's been again another great show, and see you again, all of you, in our next edition coming out next week. Bye-bye.
Bye. Thanks so much.
Bye.